HSCRG. Okay, sure. I'll just run through the admin stuff. This evening's meeting will be live streamed to the public, and the recording will be available on the council's website in 24 hours. If remote participants can use the hands up item for questions and comments, and turn off your camera and microphone on when speaking. Sorry, turn your camera and microphone on when speaking and off when finished. And the same for members and officers in the room. Switch your microphone on when speaking and off when you finish speaking. Okay. Apologies for absence.
Yes, Chair, we have apologies from Councillors Agley and Councillor Pitts.
Thank you. Minutes of the last meeting. Minutes of the last meeting. Okay, thank you. Any disclosures of interest? Any urgent business?
None, Chair.
Yep. Any references from committees or other bodies?
Again, none, Chair.
Thank you. Okay, not too much for me to say, except that since the last meeting, I attended the Luton Health Watch AGM, where the emphasis was very much on primary care access. I see. Yeah. Okay, if we go on to the first item, timeliness of TTAs and impact on bed blocking. David.
Thank you, Chair. Good evening. So I think that the sort of question that was asked was whether the potential delays that we might be having in the hospital around TTAs, which are to take away medicines, so when patients are discharged, they are prescribed medicines, and were the delays in that process ones that were effectively impacting on bed blocking and the whole emergency pathway. So hopefully the reports that I provided is helpful in terms of describing both some of the reasons why there are delays in that process. So the process really requires a number of different steps, but and usually involves the junior doctors preparing the TTAs or the prescriptions for TTAs, following their morning ward rounds, and then the process goes through into the pharmacy. That process can be prone to delays for a number of different reasons, one of which, for example, might be that the junior doctors might be called away to deal with emergency situations, or might decide that we need a fresh set of blood results and we need to wait for that. And then when they're in the pharmacy, we do have pressures within the pharmacy, particularly post-COVID, and that's to do with both an increase in the level of activity, but also in terms of vacancies. So there are quite a high level of vacancies within our pharmacy departments at the moment, which reflects some of the national workforce pressures. Now we're doing a number of things to mitigate that, and we do, as hopefully you can see from the report, we do measure this constantly, and we do ensure that we try and meet our target. The target is for us to turn them around in pharmacy within 2 hours of receiving them, and the data on the third page, I think, shows the average completion time, which you can see has come down in the most recent data. This is a problem in most hospitals. All hospitals, to one degree or another, have process problems in terms of trying to make sure that that pathway in terms of junior doctor through to pharmacy is completed in good time. I think that it certainly does have an impact on the patient experience. So patients who become frustrated when they're ready to leave in the morning, or once they've been consultant has agreed that they are ready for discharge, then wait many hours before they can actually get discharged because of the delays in this process. So it does make a difference to patients in terms of their overall patient experience. However, in terms of the actual impact on our bed base, it isn't a factor which makes a very significant difference to that, because most patients will go out that same day. What I've provided on table 2 is puts that in context of the real underlying reasons for delayed discharge are really to do with patients waiting many days, and in some cases weeks, in some cases months, for their discharge along the correct pathway. So table 2, it's quite a complicated table, and apologies for that, but what it shows you is each of the different pathways. So the first one, for example, is awaiting transfer to the psychiatric bed. The target days for that would be 2 days. The average days that we are achieving is nearly 4. It tells you the number of patients that are on that pathway, and therefore the total number of bed days that we get delayed because of that particular pathway. So, and you can see that for some pathways that there are very considerable delays. For example, I just pick out a couple. Pathway 2, neuro inpatient rehab, the target days would be 5 days, but we're not even achieving 10. Pathway 3, which is the pathway for patients to go to permanent care, would be 3 days. We're having something like 15. So in terms of the TTA as an issue, it is an issue in terms of patient experience. It is an issue in terms of the day-to-day flow of the hospital, but it's not really an issue that impacts in terms of anywhere near the problems we face in relation to discharging patients. And clearly, the reasons for the delays and the discharge on table 2 are complicated and multifaceted. Some delays are for patients being discharged into health care or other health facilities. Some relate to local authority packages of care and local authority step down. Some are to do with safeguarding, some to do with housing, and as you can see, all sorts of issues there. Family disputes is another large issue in many cases. So perhaps I'll stop there in terms of and open up for questions. But just for reassurance, we are doing an enormous amount of work to try and get our TTA process much slicker. We make sure that the pharmacy team we have a three times a day bed meeting at L&D to try and report on and identify where those delays are. But I would have to say that the 2 fundamental issues which really affect TTAs are, one, the overall emergency pressures, which put much pressure into the system, and obviously that is exacerbated by the delayed discharges that we face. But secondly, also the workforce issues that we've got within the pharmacy department, where our vacancy rate is running something like 15%. So those are the 2 underlying issues. But I think that the most significant issue for us as an organisation are the issues we face in table 2. Thank you, and I'll be happy to take any questions that I have.
Thank you, David. Any questions? Steve?
Just looking at table 1, obviously the last column relates to where it says average completion time in minutes. Can you confirm that's the average completion time of all 100% of patients, not just the percentage those that have completed in 1 or 2 hours? Because some of those numbers seem a little bit out based on the percentages of the previous 2 rows.
No, they're well, just to be clear, that they are the average between once it gets to pharmacy. Just to be clear, so that's the pharmacy turnaround time. There will be delays potentially before that in terms of the patient being delayed from the time that they are declared fit for discharge and the time the script gets to pharmacy. But no, that includes all that's the average completion time. So, for example, I think on the first line there, of all the patients, 26% are completed in 1 hour, and then 57% completed in 2 hours. That makes sense.
Thank you. It's just, like I say, to use 20th of June for an example, they've only got 65% to be complete within 2 hours, yet the average completion time is 105 minutes, which would suggest a lot of that 28% that are in an hour would be within 5 or 10 minutes in order to get a average completion time of an hour and 45 minutes.
Yeah, I'll double check the figures, but they look right. In terms of it, on the far right hand side, the average completion time is about has been about 100 minutes. Our target is to get that within 2 hours, and obviously we don't always achieve that in certain weeks, but in the majority of weeks we were achieving a turnaround time of 2 hours within the pharmacy department. The delay is more significant in terms of the delay between the TTA getting to pharmacy. And pharmacy, I think, are doing a decent job in terms of turning them around. But often the junior doctors, and obviously we have shortages again in that level, are very pressurised on the wards and often called away to do other things, and that can delay it by many hours. So we are conscious of the impact of that in terms of our patients, and it is very frustrating for patients to not necessarily always understand quite why it's so complicated to get their discharge medicines ready for them to take away.
Thank you.
Anna?
David, it's me that actually started this request because I was in hospital on the rapid recovery programme and was in a high dependency bed. And I was told in the morning that I could go home that day, and I had 2 consultants, so there was a little bit of thing. But I've got my prescription here, and it was verified presumably verified means the pharmacy, it's got initials, at 15:30. Now that prescription wasn't brought up to the ward until 7:30 that evening. And that was where, and when I actually got the medicine, talked to it, I said, can I have a wheelchair to take me to the car? And they said, yes. And the ward, who was desperately waiting for me to vacate that bed, well, that area, because you just push your bed in, they actually came down with their wheelchair and they took me back to the car so that the ward that I was in somebody from the ward didn't have to take me. But it was the length of time, as I say, verified date and time, 21st of June, 15:30. And the sister was actually chasing that prescription as well, because I was being a nuisance.
Yeah, I can absolutely imagine that that's right. So what obviously table 1 shows is the average completion time, but clearly some scripts, which sometimes may be more complicated, or there may be particular issues, or maybe a particularly pressurised day. So there would definitely be some longer waits than here, but that's the average. So some are shorter, some are longer, and I apologise to you if you were ones who waited much longer. We are very conscious of the frustration that does cause amongst our patients, but we do want to get our patients out as quickly as possible, because the quicker we can get them out in the morning, the much easier it makes later on in the day. We have a big mismatch between the time that patients are admitted, the sort of peak hours at which they're admitted, and the times at which they're discharged. So anything we can do to bring the time at which we discharge our patients forward, we want to do. So it's really in our interest to get patients such as yourself discharged as quickly as possible, because we need those beds. We need to turn them over rapidly if we're not going to have blockages in A&E and blockages back up on ambulances. So we do have a big incentive to do it, but the pressures within the service are not allowing us to do it as quickly as we can. All I would say is, if you look at that data, it has shown that we have made a lot of progress over the more recent months in terms of getting quicker at it, but some patients do get delayed.
And since I've actually started talking about this, people have been saying the same thing. They've been told that they can go home, and the length of time they haven't told me about the proof that I've got, that I had to wait 4 hours. And the reason I was bouncing up and down, for the very reason that you've just described, that there was somebody in an ambulance waiting to go into A&E, and there was somebody on a trolley down in A&E waiting to go to a bed. And I just wondered if there was some way that people who are being discharged, I know there's the ward stuff, but, a high dependency bed being left for practically a whole day isn't the most ideal thing.
No, it's not. And sometimes we obviously try and use things like what we call the discharge lounge, where patients who are ready for discharge and don't need to be in a bed necessarily can be ambulant and wait in our discharge lounge. So that happens for some patients. That's not always appropriate for all patients, but that's one way of trying to make sure that bed is available, which we do try and use. The issue of TTA process is a problem in every hospital. Trying to get that process to work. It's pretty much the same process in every hospital. Every hospital I've worked in, it's always been an issue, and all hospitals are trying to make it as slick as possible. But you're right that one of the ways is to try and make sure the patient isn't blocking that bed the whole day. Put them in somewhere where they can wait, which might be a discharge lounge, where they're looked after by nursing staff. But we don't have necessarily lots of facilities like that where patients can wait, often because we are using them as bedded areas because of the pressure in the system. I would like to take the opportunity to just say that this is one of the most pressurised times we've ever faced because of the volume of activity, the problem we have in discharge, and the workforce problems that we are facing as an NHS. And the TTA process is one of those things which gets affected by that more than anything. I'm absolutely committed to try and get this right for our patients and for the hospital. So I can assure you we're spending a lot of time. And we have got an excellent pharmacy department with some excellent leadership, which is working on this constantly to try and improve. And as you can see from the data here, we do monitor it closely.
Thank you.
Thank you, David. It's reassuring that the average times are coming down, and it's also reassuring that not just the TTA delays, but all the other delays, you're monitoring those closely. I guess the summary sentence right at the end, that seems to be a pretty good summing up. That it's obviously a source of frustration to the people involved, but it's not a significant factor in the overall context of discharge delays. Thank you. We appreciate the time and effort that. Oh, sorry. Omi, please.
Oh, sorry. Yeah, I did have a quick question. Actually, quite similarly to your story, my dad was recently in hospital and he was ready to go sort of actually pretty much the day before. We were waiting in the morning for the TTAs and it got to about 4 p.m. and he still hadn't had anything and he just decided he's going to go home. Nobody wants to stay in hospital any longer than they need to. And because of that, which is partially his fault, his updated medication list wasn't updated. And they hadn't had the discharge letter prepared. It got sent out a week later. Lots of things happened. And that was entirely because they couldn't sort out the medications in time. And that's not just 4 hours. If you start at 8 o'clock in the morning, that's another 8 hours that was delayed, his prescription. So I can see it's an issue. And of course, in the grand scheme of things, there are much more bigger issues that are blocking the beds. But that's why I just wanted to touch upon the discharge lounge again, because I know it's an issue everywhere. The hospital that I work in, the TTOs always take forever. Why are we not utilising places like discharge lounges more so that we're not blocking the bed, and also so that the patient doesn't feel like they're stuck in this hospital environment in a hospital bed, and they can sit in the discharge lounge where there's like a TV, and that's what it's like in my hospital, where it's just you can sit down, you're not in a bed. Perhaps we need to sort of utilise that sort of strategy a bit more. I know it's difficult. We might not have a big enough discharge lounge. And the other thing, which I just thought was a little bit odd, was that we said the level of COVID absence should reduce in the coming months. But actually, we are in another wave at the moment. Where I work, we've got loads of people off sick in COVID. And I don't know if if the COVID absences, they probably are reducing, but not to a level where it can entirely improve. Having the pharmacists stop doing audits and that sort of thing is okay for now, but of course all those things are important as well. But is it just the case of we need more staffing rather than accepting that there are going to be staff absences and that sort of thing? Thank you.
Yeah, just to respond to that, I think there's a couple of points there. Firstly, I absolutely agree about the discharge lounge point about, but it's a practical issue of given a number, and you can see the numbers of patients we discharge per day. We're doing around 110 TTAs a day, so trying to create enough space to manage that sort of patient discharge is difficult. So we do have a limited discharge lounge, but it's not suitable for all patients. And in terms of that delay from the morning, often what happens is a patient might be seen at the start of a ward round, but that ward round may go on for several hours by the consultant with the junior doctors, and only at the end of that ward round may the juniors then get down to doing their script. So as you say, it's a problem in all hospitals. In relation to COVID absence, I think, yeah, maybe that was slightly too optimistic. We are seeing, we're still in or have been in a COVID wave. And it's fair to say that actually our staff absence is higher than it was pre-pandemic, even after taking account of COVID. And I think that's because staff morale, staff are exhausted, and actually they've got a slightly lower threshold for sickness than they had pre-COVID. I think there's a lot of staff who do feel exhausted, and in fact that's reflected by the national figures which show how many staff have retired from the NHS. So it is about staffing, but it's not about money in this case. It's not because we don't want to recruit those staff. It's because we've got high vacancy levels. So we've got posts, we've got the established posts, and there is a point that I did make in the report about the fact that the pharmacy in particular is coming under pressure because there's a lot of money going into pharmacy posts in primary care, and we are seeing staff moving from hospital settings where actually sometimes you have to work antisocial hours and work into the evening and work weekends, and taking up posts in primary care where it tends to be much more 9 to 5. That's an issue for us, and I would be keen that we try and create a pooled pharmacy resource across the whole health community, and then the staff would rotate between pharmacy roles in the community and pharmacy roles in the hospital, because we do find it hard to recruit. The acute hospitals pharmacy roles do have more antisocial hours, they do have more pressure, and actually the number of roles that are now created in primary care is creating a pressure for us in hospitals.
Okay, thank you.
Anyone else? Okay. Thank you, David. Appreciate the time and effort that's gone into compiling this report. Yeah, thank you.
My pleasure. Thank you very much.
Okay, moving on to the next item. I think, are we still item? Yeah. Okay. So if we can take item 9 before item 8. Coverage of cancer screening for the population of Luton. Kathy?
Hi, good evening, everyone. Is my camera on now?
Yes.
Wonderful. Thank you for the invite to come and talk to you. My name is Kathy Nelson. I am the head of the Cancer Network for BLMK ICS, and I just wanted to talk to you all about screening programmes and the work that we are doing to improve coverage of that. Can I start with how important it is for cancer screening? It saves lives, and we have an early diagnosis programme to support the uptake and increase of screening across bowel screening, cervical screening and breast screening. And we're doing that in order to make sure that we identify cancers much earlier in the process. And we know in Luton there is a theme around poor cancer screening uptake, and we're doing all that we can to improve that. There are two key messages in the paper that I wanted to share with you all. One is during COVID, a lot of the screening programs, in fact, most of them were paused during the early phases of COVID, and we've done a lot of work to recover those and restore them back. So all screening programs since early 2021 have been fully restored and recovered, and therefore and reducing the backlog of patients that had built up during that time. The next point that we need to make is that if in terms of the long-standing challenges of uptake, sorry, bear with me a second. The long-standing issue around uptake in Luton, we're doing a lot of work with our PCNs. So this is a kind of whole system approach to improving the uptake, and we're doing that with our colleagues in public health. We are doing that specifically with our practices and PCNs, and we're also working with other organisations to raise awareness. So we've got a lot of community engagement happening so that we're tackling the public's perceptions of screening. One of the ways that we did that was to do a survey in Luton, but also the rest of BLMK, around why people felt they couldn't access cervical screening in particular, because cervical screening is the programme that we need to focus our efforts on. That's where we have the lowest uptake, and it's particularly in younger women in the age brackets of 25 to 49. And that survey revealed some things to us that we didn't know before. So sometimes we have assumptions around, access to services, and that helped us to refine our thinking so that we could make sure that the training for practice staff was tailored, and we will continue to do that. Again, some of the feedback that came out from the survey we've been able to share with practices, and they have adapted their communication methods with patients around the importance of screening. So a lot of the practices now will follow patients up and have those conversations rather than just send a letter to say you haven't attended. There are conversations now happening. There are video messages that are going out to patients, and sometimes in different languages as well. So we're trying to bespoke that communication with the public around screening. So there were the two main areas that I wanted to talk to you about. There is still much to do around increasing uptake across 3 screening programmes, but I just wanted to raise with you, we are trying to target those efforts to maximum impact. So I didn't know if anyone had any particular questions. Happy to take them. Thank you, Chair.
Louis, please. Yeah.
Pressing the wrong button. Thank you for your report. It was really interesting. So my question really is, in Luton, we've got an interesting population where a lot of young people probably are from different ethnic minority backgrounds. How much are we tailoring the advertising or the promoting to the different backgrounds where it might be a little bit taboo to do things like cervical screening? And how are we getting to the sort of younger end of that 25 to 45? So I interestingly saw a TikTok the other day from one of the councils that did a myth-busting video on breast cancer and that sort of thing. Are we doing that sort of thing? Would we find that useful? So yeah, just want to hear your ideas. Thank you.
Absolutely. And so if I start with the new ideas first, in terms of the younger age group, when we did the survey, we realised that we needed to do things slightly differently to get people's views. And so we sent the survey out to places that we wouldn't normally go to. So we sent it out to gyms, hairdressers, places where younger women would go or to be able to see that survey, and we actually got quite a good response. We had over 200 responses to that survey, and some of the things that came through were around body image, embarrassment, all of those things. So now we're trying to think about innovative ways of how we tackle that, and it wasn't necessarily what we thought, which might have been oh, sorry, I can hear feedback. Thank you. It wasn't necessarily about access and those traditional things that we thought we might see. So I would be happy if you've got ideas. We as a team would be more than happy to receive those in terms of those kind of innovative ways of doing that. What was also interesting about the cervical screening is that people didn't always realise it was a cancer test. Some of the feedback we got from the surveys that they thought it was maybe a sexual health test and not necessarily to identify risk of cancer. So that's another message that we now need to try and tailor. I just want to add that we have just recruited in Luton Borough Council have recruited on behalf of the cancer programme 4 community connectors, and that's a way of engaging with communities. As you say, we've got diverse communities in Luton, and we want to try and reach out to them to see what their barriers are, but also to help shape how we can do things differently. So we have 2 out of the 4 posts now recruited, and we will continue efforts to recruit the other posts, but that is our ambition to make sure we reach out to people.
Great, thank you. Thanks. It's good to hear all the things that you're already doing. I will probably drop you an email and maybe send that TikTok to you because I think it might be helpful.
Thank you very much. Yeah.
Thank you. Anyone else? A couple of questions, Kathy. You just mentioned community connectors. Can you talk a bit more about that? Is it anything to do with the core 20+5 ambassadors? Is that a similar thing?
They will be similar. These are specifically focusing on cancer early diagnosis. And if it comes up around people who've already been diagnosed with cancer and the support that they need, but primarily these are Macmillan grant funded posts for 3 years. And the intention was that I don't know if people are aware, we have a project specifically around Luton, our Luton Cancer Outcomes project, to address some of the poor outcomes for cancer in Luton, 1-year survival and screening uptake being part of that. And we kind of did a lot of work around what do patients want, what does the public want to see, what are their barriers, and we realised we need to ask people. So the idea of these community connectors came out of that, really, is how do we get an open dialogue with the public to improve access and outcomes. So they'll have a project lead, a coordinator, and then 3 other posts. One will focus on Southeast Asian communities, one will focus on Black, African, Caribbean communities, and one focus on Eastern European communities specifically. But it's for the whole of Luton population, but there'll be some targeted messages around those particular communities as well, to try and, like I said, improve uptake of screening and patient experience, all of those things.
Thank you. That's good to hear. One other question. This report is obviously about cervical, breast and bowel cancer. What about other cancers such as thyroid or prostate?
So prostate, thank you for raising that. We are just in the process of working up a pilot that we want to do around prostate cancer, because we now know that during COVID, our diagnosis rates for prostate cancer dropped, and we want to do more to make sure we get that back where it should be, again, so that people aren't presenting at later stage and then having to have more treatments, potentially having an impact on their life. So we will be working with our PCNs. Again, it's about that joined up approach with primary care. How do we case find people? So other cancers will hopefully then follow, but we're going to test it out with prostate cancer because we know that's the one where we saw most of the drop during COVID. Other cancers we will work on as well as part of our programme. Our cancer programme covers all cancers, but there's something about us trying in terms of early diagnosis, and you mentioned the core 20+5. It's about where those inequalities lay, and so we're trying to make sure we address those.
Okay, thank you. Pat.
This is Pat from Healthwatch. I mean, organisations often put their surveys on Healthwatch's website, reached by a lot of people, I think, yeah.
Yes, thanks for mentioning that. Thank you.
Thank you.
Anyone else? Okay, thank you very much, Kathy, for your report. Thank you.
You're welcome. Thank you very much for having me.
Okay, back to item 8, modernising inpatient mental health service in Bedfordshire and Luton update. Robin? We have Robin.
Hello, good evening. Can you hear me?
Hello?
Hi, good evening. Hi, how you doing?
Fine, thank you. We can hear you, we can't... Yeah, there you are.
Here we are. How are you?
Hey.
Right. Would you like me to start? Can I start?
Yes, please. Yep.
Brilliant. Okay. So hello, good evening. And my name is Robin Campbell. I'm the Deputy Director of Integrated Care for East London NHS Foundation Trust. I'm here to update the committee on progress with the modernising inpatient mental health services in Bedfordshire and Luton programme. As you'll know, in October 2021, ELF, together with BLMK CCG, or the ICB as it's now known, concluded an engagement process on the case for change. In November 21, this committee received the report of the engagement process, and members were advised that a total of 273 stakeholders participated, with a very positive response, and a number of very helpful questions and comments have been built into our clinical strategy. Since this time, the Trust and ICB have continued to undertake further preparatory work to the development of the pre-consultation business case, which is in line with the NHS England process for service change. This has included an appointment of an architectural design team to undertake updated studies of the Bedford Health Village site, including the range of design options, considerations and costs, taking into account the current macroeconomic environment in our options development. And we're aiming to complete this piece of work in autumn. Secondly, we are developing our clinical strategy, which will outline a proposed clinical model and address considerations and questions raised in the case for change engagement process. A key principle for the clinical strategy will be the future proof of the inpatient mental health services and meeting the changing needs of the population we serve, ensuring the highest possible quality recovery orientated environment for our service users. And again, we're aiming to complete this by the autumn. We've also commissioned work with BLMK ICB and Bedfordshire Hospitals Trusts to develop a site master plan for the Bedford Health Village site, which again, we're aiming to complete this autumn. And lastly, as the committee will know from September, the new CAMS Tier 4 General Adolescent Unit Evergreen Wards build and mobilisation is nearing completion, and we're aiming to open that ward in 2023. The modernising inpatient mental health services in Bedfordshire and Luton will build on that programme for CAMS, and we're looking to expand those beds for general adolescent, as well as building a psychiatric intensive care unit or PICU unit. The committee will have noted in our previous updates that we are required to confirm capital development expenditure limits to cover in place before we can proceed to substantive next steps, including the finalisation of our pre-consultation business case, which we'll bring back to this committee for discussion and approval. As part of this capital limit process, we have expressed an interest in joining the new National New Hospitals Programme in autumn 2021, and this announcement has unfortunately been delayed, and we await that at the moment. Should the application be unsuccessful, we will of course be exploring other options for funding with our partners. Lastly, it's proposed that an update is brought back to this committee when funding options have been explored further, or a request to move to the pre-consultation business case is sought. Does anyone have any questions?
Thank you. Anyone? Steve?
Obviously, you say the new hospital programme that's been delayed. Do you have any? I appreciate if you don't, given the situation in central government, you got any idea when any decisions on that are going to be made?
Yeah, it's a good question. We've just recently chased the East of England region on an update, and I think the answer was fairly unclear at this stage because of the changes in government, as everyone can expect. So unfortunately, we don't have an update at the moment, but we continue to pursue that avenue.
So a case of how long is a piece of string at the minute, as I'd expected. Thank you very much anyway. I know it's frustrating.
Thank you. A question about the Capital Department Development Expenditure Limit cover, and you need that before you can proceed with the programme of work that you have planned. If you don't get that cover, what is there another? Is there a plan B? Is there another route to? You say you will explore other options with our partners. What would those other options be?
So there are a range of options in terms of funding. What you absolutely have to have as a minimum is the capital approval. So you could have the funding in your accounts, I suppose, in an NHS Foundation Trust, but you have to have approval from NHS England to spend that said capital. So whilst that's certainly a challenge in getting that approval process agreed with NHS England, it's only half of the challenge. The other half of the challenge being, where does the funding come from? So partly that's a possibility is the new hospital development programme, but there are other options that we would obviously look to explore with partners, and that may mean a multitude of cash or funding sources. That could include redevelopment of Elft Trust Estate, and councillors and committee may know that a number of other schemes across the country have been funded in part by doing that. So you work with house building partnerships, if you like, to raise capital in that way. Other options that we would look to explore would be other NHS England pots of funding that's become available. I think the critical thing here is to make sure that we're ready with our plans and our detailed schemes, so that when money does become available, we're absolutely ready as a system to be able to apply for that. I think that's the kind of key messaging, really. So we'll be exploring every option that's available to us, really. And as I said, the kind of key thing is being absolutely ready, which is what we're planning to do over the coming months.
Thank you. You're developing the clinical strategy. Is that development dependent on the funding, or is the strategy independent of the funding?
Thanks. Yeah, so the clinical strategy is part of the process, but it's certainly independent, and it's something that we want to complete prior to the pre-consultation business case and prior to approval for the capital approval and funding. Essentially, we really need to have our kind of schemes kind of really well thought through in terms of what's our clinical strategy, what's our funding model, is it feasible, is it sustainable, all the kind of key questions that you're going to get from both the system but also NHS England and the Treasury to be able to get that approval in the first place. So yeah, absolutely. These are kind of, it's really laying the groundwork for those discussions. As I said, so we're absolutely ready for those conversations.
Okay, anyone else? Okay, thank you, Robin. Thanks for presenting your report, and we look forward to hearing from you when the funding options are settled, I guess, one way or the other, and also to looking at the clinical strategy when that's ready.
Absolutely. Thank you for your time.
Okay. So if we go back to, sorry, just for one moment, go back to item 9. The recommendation was to note the report and support the screening uptake action plan. So I imagine that's okay. Yeah. Thank you. Okay. Draft work programme reports 22-23. Anyone have any comments on the proposed work programme? So the one for the next meeting, 23rd of November, has been updated somewhat so that we now have reports coming on sickle cell disease and the sport and physical activity strategy. Okay, thank you. I think that's it, unless anyone in the room or online has anything else to add. Okay.